Dr. Santosh Honavar, and we are so blessed to have Dr. Honavar sir is with us today. He doesn't require any introduction. He's the Honorary General Secretary of All India Ophthalmological Society, and he's the mentor of all the mentors. Over to you, sir.
Thank you, Marian, for the kind invitation, and I appreciate that you sacrificed your talk, and I'll try to finish it early so that you can also squeeze in your talk. I'll be speaking very quickly on oncological principles which can optimize outcome in oculoplastic surgery and restrict myself to orbital surgery so that Marian can get some time to talk. Orbit is a Pandora's box full of evil. That's because 50% of orbital tumors are malignant, and thereby lies the implication on life and eye salvage as such. So that is the reason why you should actually combine your oculoplastic surgical skills with oncological principles when you manage orbital tumors. That will optimize outcome. Now, what are the oncological principles? I'll give this to you right away. Oncological principles in orbital tumors are irrespective of what the tumor could be, benign or malignant, based on your clinico-radiological evaluation. If it is well circumscribed, then you must completely excise. There is no role for an incisional biopsy in a well circumscribed tumor that is not affecting critical structures in the orbit. I'm not talking about optic nerve tumors here that are well circumscribed, but I'm talking about tumors which are well circumscribed, which are not affecting the critical structures in the orbit. Then when you want to excise, you go to minimal interventional techniques. Minimal dissection of planes, minimal cutting of bone. If at all it's required, we don't cut the bone anymore. And whenever you want to do incisional biopsy, it should be multi-level or at least past the epicenter. If this is a tumor, you have to go beyond the epicenter of the tumor to take an incisional biopsy, not just the superficial part. Whenever it is indicated, you have to get an intraoperative diagnosis so that you know exactly what the tumor is. Based on that, you can take some intraoperative measures, whether to go ahead and debulk it, irrespective of what happens to the ocular motility or not. If it's a highly malignant tumor that cannot be dealt with by any other modality except surgery, you have to do surgery. And that is the reason why intraoperative diagnosis becomes very crucial in certain clinical situations. Then finally, HP-guided adjuvant treatment. You have done the surgery, pathology tells you some information. Based on that, you have to go ahead and treat the patient. Unless you do that, your treatment will be incomplete. In certain situations, we use surgery, radiation, and chemotherapy in a specific combination. Surgical approaches are many, but we currently believe that less is more, in the sense that we use transconjunctival orbital approach to a majority of tumors. At least about 70% of the orbit can be accessed by transconjunctival approach, except the superior part where LPS comes in the way. So that is what we do. I'll skip the video, but basically a patient who has an intraconal tumor like this can be accessed by inferior transformational approach. Left eye, you can't even see a scar after 3 weeks after surgery. All that we did was a small lateral canthotomy and inferior cantholysis, and the tumor was accessed by the inferior transformational approach. Now about incisional biopsy, we all know the indications, but mainly any tumor that is ill-defined or is involving a critical structure where you can't clinico-radiologically pinpoint a diagnosis deserves an incisional biopsy. So suspected malignant tumors, poorly localized and infiltrative, associated with critical structures, if you want to excise that, those critical structures will be damaged, and you don't want to do that unless you know what it is. Intraoperative diagnosis is required. But whenever you do it, it has to be a direct approach. I will show you this pathetic example, sorry to use that word, of a lacrimal gland adenoid cystic carcinoma where the surgeon has done a lit crease approach and has just done an incisional biopsy. The tumor has promptly come back after radiation and chemotherapy that they did. And where has the tumor come back? Tumor has come back here, tumor has come back here, all under the skin flap. Why? Because an incisional biopsy will seed the tumor in multiple planes. And the radiation oncologist would not know what all planes have you seeded. He would give radiation in this area. And the same patient has also undergone a lateral orbitotomy bone cut, which was not really required in adenoid cystic carcinoma. And what has happened? Tumor recurrence is in the temporal fossa as well. So you should never attempt lit crease incision in a suspected adenoid cystic carcinoma, because you're going to seed the tumor all along the suborbicularis plane. you have to do a direct approach right over the lacrimal gland with a direct perpendicular incision and a transeptal or transarcus or transperiosteal incisional biopsy. The second concept is about 8 to 20% of orbital biopsies result in non-specific or misleading diagnosis. That's either because of a bad sample or because of non-uniform tissue pathology. I will show you an example of a child with rhabdomyosarcoma. When I do a biopsy, I do a superficial, mid-zonal, and pass the epicenter and send all this to my pathologist. As part of the study, we did this. But generally, what is important is that you should go past the epicenter. You know the epicenter on radiology anyway, so you should go past the middle of the tumor. That is what is important in incisional biopsy. Now let me show what the superficial biopsy showed. This clearly shows that there is inflammation and sclerosis. So if I were to stick to superficial biopsy in this child, the diagnosis would be non-specific inflammation. Based on that, somebody would have treated this patient on oral steroids, which would have anyway delayed the diagnosis, appropriate diagnosis. Only the deep biopsy revealed embryonal rhabdomyosarcoma in this patient, and of course the child responded. So you have to go past the epicenter of the tumor. That is when you do incisional biopsy. Then multi-level biopsy is important. Right. Then the intraoperative diagnosis. A child like this, where there is a quiet tumor lying there for about 9 months, your clinical diagnosis would be eosinophilic granuloma. But it could be anything. But it has destroyed the roof of the orbit. The dura is involved. So you can't be very exploratory or aggressive in this situation. So what I would do is direct approach, biopsy right from the center of the lesion, without disturbing the dura or the superior rectus LPS complex. You get the diagnosis that it is eosinophilic granuloma. All that you need to do is inject triamcinolone within the lesion intraoperatively, and over a period of 3 and 6 months, the bone completely remodels without the need for a major surgery. So intraoperative diagnosis is recommended whenever you have a doubt about the diagnosis and when you don't know what is the next step to take. Pathologist will tell you what is the diagnosis within 10-15 minutes, and thereupon you can take your correct approach. And what if you have excised the tumor completely and know that you have excised the tumor completely? This patient had a SFT involving the infraorbital nerve. I have taken out even the nerve. But beyond that, it was an aggressive tumor. So what do you do in an aggressive tumor of this sort? You have to go ahead and give stereotactic radiation. Like orbital lymphoma, you have done an incisional biopsy. When it is shown that it is mantle cell lymphoma, you have to go ahead and give rituximab. Finally, about multimodal treatment. There are situations where orbital exentration may be your primary choice of management, but that results in very high mortality. So in such situations, you may want to conserve the eye, you may not want to conserve the eye, but you have to employ surgery, radiation, and chemotherapy, all the modalities. Here the steps are that we have to do biopsy to confirm the diagnosis, then provide adjuvant chemotherapy, biologicals if required, and stratify the risk, and finally treat the patient. This has been very well used in retinoblastoma. You can see all this with good success. Cosmesis is the bonus in such situations. In rhabdomyosarcoma, where you want to preserve the extraocular muscle, inferior rectus has been preserved here by creating a wedge which has been left out, and rest of the tumor has been removed, and rest of the treatment obviously is with multimodal treatment. Even when you want to do orbital exentration, you can reduce the size of the tumor and make this surgery safe for the patient. And in adenoid cystic carcinoma, the role of multimodal treatment has been established, where you begin with neoadjuvant chemotherapy, shrink the tumor down, and then do just the en bloc excision without bothering to do orbitectomy, which we used to do earlier. You can see bone completely remodeled over a matter of 6 to 9 months following this treatment. A child, again, completely remodeled bone. For recurrent adenoid cystic carcinomas, we can devise afterloaded interstitial brachytherapy to the bed of the tumor by using iridium-192 sources with much better outcome. So in conclusion, I would say that oncological principles actually help salvage a lot of life, eye, and vision, of course, vision in orbital tumors. Thank you so much.
Thank you so much, sir.